Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
All right. Hello, everyone. My name is Kevin Mercer. I'm an emergency medicine pharmacist and assistant professor and research coordinator in the Houston, Texas area. I wear a lot of hats, but recently one of those hats was speaking at a national conference in Atlanta, Georgia on cardiac arrest with one of my physician friends and colleagues. Interestingly, this physician and I have never practiced together, but brought together through mutual friends and our significant others. And so he's an emergency medicine physician at the Atlanta VA and does a lot with simulation and ultrasound teaching with the residents that float through there and the other learners that float through the VA. And so we came to present this topic on pseudo-PEA management, since I would mention this sometimes to colleagues, both physician, pharmacist, nurse, and otherwise, and always get kind of a bit of a puzzled kind of response. So in putting this together, we used a patient that kind of came through one of our emergency departments, and I can share a little bit more about with you here. So this was a case that we had who was a 68-year-old male with past medical history, hypertension, and heart failure. He originally came in from his cardiology clinic because he had an abnormal heart rate that was found to kind of be SVT. And he had associated shortness of breath and bilateral lower extremity swelling. His SVT was treated with adenosine without a rhythm change, so it was possible that maybe it wasn't administered in a way that the patient could truly receive the medication appropriately. He also was found to have hypokalemia and acute kidney injury, and point of care ultrasound, or POCUS, showed an EF of less than 30 and an IBC that was engorged greater than 2 centimeters. He was ultimately treated for heart failure exacerbation and received some IV metoprolol. And you can see his initial EKG when he came into the emergency department here on the left. So it showed supraventricular tachycardia. This case continued to evolve and the patient ultimately arrested. But one of the things that we introduced during our presentation was this concept of pseudo-PEA, or pseudo-pulseless electrical activity. So as you may know, PEA is organized electrical activity without a palpable pulse. However, this is very heterogeneous. We know from the literature that it's very difficult sometimes for code team to palpate a pulse. There's a wide variety of literature out there stating that, up to 50 or 60% of the time that the patient may or may not have a pulse, but we do or do not detect it. And so using other things to detect a pulse in these scenarios can be really important and can also help with just providing an overall more holistic care. And so in identifying patients with pseudo-PEA, we break PEA down into PRES and PREM. And you can see here that PREM is pulseless with a rhythm and echocardiographic motion. And then PRES is pulseless with a rhythm and echocardiographic standstill. Now, we think that PREM is more of like our pseudo-PEA. So it's when our patient is in a cardiac arrest, they don't have a pulse, or at least a palpable pulse, and they still have some echocardiographic motion. So the heart is quivering, the heart is beating a little bit, but so slowly or without enough force that it's not generating a pulse. There's also some differentiators here, and there could be some additional branching from this where we feel that PREM is truly with a pulse rate greater than 60, or there are some other cutoffs there. But essentially, PREM is where patient is in PEA, but they have some sort of echocardiographic motion. It's thought that these might be the patients that may benefit from some additional resuscitation, or maybe not giving up on our resuscitative efforts. Whereas PRES, on the other hand, pulses with a rhythm and echocardiographic standstill. So again, this would be maybe true PEA. And maybe at this point, with enough interventions from our entire code team, that it might be best to consider calling the code or stopping resuscitative efforts, as there is no echocardiographic motion. There's nothing to really revive here anymore, unfortunately. So this was our patient CD. You can see here that compressions were ongoing. He ultimately arrested in the emergency department after all of his SVT and heart failure treatments were underway. Pulse checks continued to reveal no pulse with organized electrical activity. So again, this patient was in PEA, but POCUS identified that the patient had a demonstrated low EF, but we did have cardiographic motion. So this would kind of put him in the PREM bucket or pseudo PEA. So during this time, this was not a patient during my shift, so I was not directly involved with this patient's care, but he was initiated on various vasopressors, including vasopressin. He had already been placed on norepinephrine and dobutamine before this, and epinephrine was also, an infusion of epinephrine was also starting during the resuscitation. So when we talk about managing someone's PEA and pseudo PEA, there are some attempts that have been made in the past to really address how to optimize care in this kind of realm. And so there was this algorithm that was developed to treat PEA, and we kind of extrapolated this to how it may be applied to pseudo PEA. And so you can see here at the top, we start with, is the PEA or pseudo PEA narrow or wide, complex? And then do we really have like a hypokinetic or hyperdynamic LV? And so we can see where on the right with wide complex and a hypokinetic left ventricle, we may be concerned for things like hyperkalemia and sodium channel blocker toxicity. These are things that we can provide pharmacotherapy for and maybe reverse and maybe resuscitate and maybe get our patient ROSC. Whereas on the left, in narrow complex, this is all about if the right ventricle is collapsed or if it's full, and what kinds of things that we need to think about if that happens and how we can reverse some of those causes. Some of our H's and T's, and a little bit more of a quote organized way of thinking of our H's and T's according to Littman and colleagues that we cited here. And so breaking down this a little further, we can see that narrow complex pseudo PEA is more mechanical versus obstructive pseudo PEA that is often reflective of a right ventricle that has an obstruction. And so in these patients, we typically want to pair wide open fluids with reversible procedure or treatment that we can use to target what we think is the most likely H or T to cause this kind of pseudo PEA. So you can see like cardiac tamponade, tension pneumothorax, mechanical hyperinflation, and pulmonary embolism here are listed, but it's kind of like just a way to organize our thinking rather than an exhaustive list. On the other hand, we have wide complex pseudo PEA, and these are usually more metabolic versus toxic versus pump failure pseudo PEAs. So this is really when the pharmacist could potentially shine if this were a validated treatment tool, and we could use targeted antidotal pharmacotherapy like calcium chloride and sodium bicarbonate, as you can see here on the right. But as I mentioned, Littman and colleagues proposed this as kind of like a teaching tool, or like an analysis they did, or patients they collected on, or any sort of an assessment that was done in a patient population. So this was a teaching tool that they developed. And so it did receive some investigators who tried to essentially validate this. And so this was a paper done by Burgum and colleagues that examined patients in hospital cardiac arrest. They identified 51 PEA arrests with a reliable cause, and they had like defibrillator ECGs to kind of back them up. And so when I say patients with a reliable cause, there was a much larger bucket, and they examined patients where they were determined to have more of like a definitive cause of their cardiac arrest. Like, multiple investigators in the study did examine the case and were like, oh, well, this is what led to their arrest. So they kind of were able to vet the arrests in that kind of way before doing more analysis on them. They found that results were all across the board. So you can see here on our graph on the left-hand side, our y-axis shows QRS interval, and the x-axis shows the PEA heart rate. And these little triangles and squares represent mechanical PEA versus non-mechanical PEA. And so again, based on the framework that Littman and colleagues put together, And we would expect these to fall in a certain way. And it's just kind of like all over the place, all across the board. So what we can really take from this is that the ECG morphology can organize our thinking, but it can't really override all of the clinical context that goes into resuscitating a patient with pseudo-PEA. We need to use our POCUS and our waveform capnography and all of the other things that we have at the bedside available if we can. So then that kind of leads us to like, well, where do we go from this? And well, we're kind of right back at square one, right? So what we do think we know about pseudo-PEA is that it's essentially a low output form of shock. So the heart is quivering or pumping, but not pumping fast or forcefully enough to generate a palpable pulse. And so these other investigators, Prosen and colleagues, also examined patients in pseudo-PEA and compared them against a historical PEA cohort. And they implemented this intervention in this small study of about 60 patients who received vasopressin. And so PEA was confirmed during out-of-hospital cardiac arrest. And then upon arrival to the emergency department, POCUS showed pseudo-PEA. And in the modified protocol, patients received vasopressin 20 units IV push, and they resumed CPR. And you can see some of their outcomes here on the right. The ICU admission was statistically higher amongst patients who did receive vasopressin, again, in this very small cohort. And then ROSC was also higher, as well as survival to hospital discharge and good neurological outcome. Now, this seems very promising, but they definitely did not meet power in this patient population. There were some other concerns regarding their study design. So essentially, this became a hypothesis generating type of study for treating pseudo-PEA as a shock physiology rather than something that we could really base this off of. This wasn't like a random or an RCT or anything like that. These are our take-home points from operationalizing pseudo-PEA care. Now, if you attended the full talk at the meeting, you'll recall that a lot of what we did was highlight that we need more literature, we need more investigations, we need more studies on pseudo-PEA because it's still very up in the air on what is the best thing to do for patients in pseudo-PEA. But what we do think we know is that pseudo-PEA is a low output form of shock. And so when approaching these patients, we can start with confirming the residual physiology and using all of the tools at our disposal, including the POCUS or the point of care ultrasound. We can also use some arterial line rhythms and a bunch of the clinical context that we can put together as a team, as a code team in these situations. If there is a definitive rescue, we can use targeted drugs or vasoactive bridging to kind of buy us more time to find a reversal for that. And so this is not necessarily super groundbreaking in a way, right? Like essentially a lot of what PEA and pseudo-PEA care is finding a reversible cause with our HNT and treating it. And so essentially this is highlighting that. And then we can reassess every cycle without worsening CPR by operationalizing our point of care ultrasound in a way that does not interrupt chest compressions. And so what one of my colleagues who spoke with me on this was highlighting was that we can get the probe in place during CPR, capture the image we need during pulse check, the 10-second pulse check, but then wait to read it for after CPR resumes so that we minimize interruptions in CPR.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only. It does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.